the embarrassment of success, though, with so much rich detail, you get more questions. But it does put things into context for the rest of the meeting. So my two questions are, first of all, on the compulsory vaccination. We're getting close to the 3rd of February for our staff. What's the scale of the issue that we might face in terms of staff refusing to be vaccinated? And the second one is for Pete. Pete says ward refurbishment works have been completed at PICU. Gives us some more detail. Can you just update us as a board, Pete, on where we are with the ligature work, please?
So in terms of ward refurb, Mike, they're all covered. So that was general environment. We got a paper at E&T a couple of weeks ago now in terms of the ligature programme and in particular door alarms. And we've agreed, I mean, Lynn may want to come into this as on the clinical side, but we agreed that we would pilot the doors in areas and then look to have a full rollout and factor that into the wider planned refurbishment works we've got for next year's capital programme. So I'm thinking in particular the scheme at the Humber Centre.
Thank you. On the question of vaccines, we've got the vaccines later on the paper on the agenda today, but I know you're leaving, Mike. Does someone want to just respond to that?
I'm happy to take it offline, Caroline, because it's on the paper later. Okay. So if Steve or myself want to take it offline later, because unless you want to bring the paper forward, I'll leave it in your hands.
No, I'll catch up. Thank you.
Thank you, Mike. Thank you, Mike. Right. Sorry, Lynn, were you coming back? Because I can see Michelle Hughes has been waiting very patiently to come in. Are you coming back on something Mike asked?
It was just on the point that Pete Beckwith has just raised around the ligature anchor point work and the work particularly around door alarms. It's just that there is a paper coming to next quality committee to give a bit more detail around that programme.
Okay, thanks very much, Lynn. Michelle, you've been very patient.
Thank you, Chair. It was just a brief highlight of the communication section. It's the comprehensive section as usual with some performance data, but I just wanted to highlight a couple of examples of ongoing staff engagement. So valuing engaging with staff continued over the Christmas period at the end of another year living and working with the challenges of COVID, and the team supported a number of initiatives, lots of people involved, lots of engagement activity, including prize draws and competitions, etc. So real ongoing engagement there from the whole team and teams around them. And another example just to highlight of listening to and responding to staff is in response to some comments we received on MST webinars, we undertook a short survey. So using the feedback from that, we actually went back to staff and we said, you said, we did. So very clear communication, very clear feedback both ways. So I just wanted to just highlight those two examples. Thank you, Chair.
Thank you very much, Michelle, for that. I cannot see any other hands up. You've got your hand up.
It was just, I wanted to end with this if there's no other questions, Caroline, because it's something in the action log that I've not raised, but I wanted to leave it till the end. So I'm happy to bring me in when you need to talk about. It's at the end of the section.
But no, if you want to come in now, Michelle, that's fine.
On the action log, there's a bit about Maister in relationship to a video. We have got some of that. There is a little piece in the report. I'm happy Peter might want to pick back with the name, want to pick this up. We have concluded a lot of the work at Maister. The reason why we're going to leave that and just bring it a slightly later, hopefully next time, is there's we're having some couple of conversations with the local councils at the moment about, we've got planning permission, but about the structure and about storage and car parking, etc. So if it's okay with the board, we'll just leave it. We'll get those conversations out and then we'll circulate the video and put it onto the website. But Pete, I don't know if you wanted to mention anything.
I think you've covered it really well, Michelle. So the scheme is all but complete. There's a couple of inquiries locally that may have to do some further work on site. So we probably thought it makes sense to hang fire for the sake of 3 or 4 weeks before we circulate the presentation and the slides and the update on the scheme.
Thank you very much, Pete. So thank you for that discussion, all the questions. Just to capture some of the, I think, actions going forward. I think there was a request to sort of use the operational planning guidance priorities and really against those, maybe pull together some of the actions that we're taking and work that is ongoing so we can see how they are already lining up together. Again, following on from earlier discussion, I think 2 parts. One is, a paper around our digital plan to be able to go into more depth about that and discuss it at board. But I think almost alongside that, and I hope I'm reflecting this in the way you wanted, Dean, is the sense of where the digital fits alongside the more sort of getting back to some sort of normal service and what that might mean. I think, you know, we talk about the blended approach, and in some ways it would be good to see how these things are actually aligning with each other, actually, in terms of the service, and that would be helpful too. So whether that will be 2 papers or 1 paper, we can decide outside the meeting, but I think those 2 things came back very well. And I think on the safety, the point made by Peter Barron about the safety side and requires improvement, and feeling that we're not, you know, it's been a long time and we've done a lot of work. I think there was a suggestion we should go back to Quality Committee and look at that work, talk about it. And I know we do talk about it across the organisation, but maybe, particularly for staff in these areas, you know, making sure that we know that they have made considerable improvements and wider understanding about what those improvements are across the trust. And for our governors as well, I think it will be really important to make sure that they are very much in the discussion on this. So I think that is everything from that. If people are happy, do we approve and Peter, sorry.
Yeah, it's I think you're about to say, Caroline, about the ratification of the 4 policies, because we hadn't discussed that, had we? So I just wanted to make sure that wasn't forgotten about, but it looks like you're onto it, sorry.
Yes, thank you, no problem. Thank you for very helpful reminder. So before we approve the Chief Executive Report, we also have to ratify the policies. Are those in favour of those policies as contained within the report? Yes, thank you. And approve the Chief Executive's report. Everyone happy with that? Thank you very much indeed. Thank you. And I think we'll move on to the publications and highlight report, and then I suggest we have a break after that, a comfort break. Michelle.
Thanks, Chair. I'll be very quick with this. It is just the normal publications and highlight report where we've looked at the national publications that have come in. A little bit of narrative underneath to say what we're doing with that. I'll leave it there. I'll just answer any questions, Chair.
Thank you very much. Any questions? I see John's hand up.
Yeah, thanks, Chair. I'd just like to sort of direct board member colleagues just to have a look at the CQC report, the out of sight. We know we've talked about closed cultures in this organisation quite a lot over the 2 years and how the CQC have moved the language on. You know, there is an executive summary of the report, which I think would be helpful for board members just to have a look at. Mike, it will be taken back into the RRI group and we can have a conversation at Mental Health Legislation Committee. And what I will just ask Jenny Jones to do is just to share with you the link to our trust webpage on closed cultures, so you can see that we have that in place, and it's an externally facing web page for patients and carers and service users to be able to look at and understand our closed culture work and understand how that works with safeguarding and how to report concerns. So it would be helpful if board members could just have a little look at that. When you are on a ward, you will see that we have posters up which have QR codes on them. So this is all digitally linked now, and that links into the digital conversation we've had. So I do think that's a landmark CQC report. They are really interested in the closed culture work. And I think it's important that we are staying on top of it, but actually there's an awareness that that's an ongoing area of focus for them, quite rightly so too.
Thank you very much, John. Any questions on this? Obviously, to my non-executive colleagues, you will have noticed in the report that there's a guidance that sets out a new approach to ensuring board oversight, and Michelle and I are going to obviously look at that and review that and probably bring a paper back in terms of, is there any learning there for us in terms of what we're doing at the moment, and we'll probably have informal discussions about that as well. Okay, so if people are happy with that, I suggest at 11 o'clock we take an opportunity to have a comfort break. Mikey will be leaving us for the rest of the session, but hopefully see you all back at 11:10, please. Welcome back, everybody, to our Trust Board meeting. And the next item on the agenda is number 9, winter pressures. We are also joined by Hanif Mag, our associate Ned, who has been, as I said earlier, a north of England NHS seminar on health inequalities. Thanks for representing us there, Hanif.
That's fine. Thank you, Caroline. As I said earlier, I'll feed back at an appropriate time to colleagues.
Thank you very much. So over to you, Lynn.
Yes, thank you very much, Caroline. So the board requested this report, not surprisingly, and so this report covers the winter period up to date. So the period starting October 2021. It sets out, and hopefully that's apparent, sort of key areas of operational performance that have continued to be impacted by winter, and as we have already talked quite a lot about this morning, the ongoing impact of COVID and the pandemic too. So I think just by way of overview, obviously very happy to take any questions. And the key theme, I think, really is one that Francis touched on earlier around the impact of the cumulative position around staff availability due to staff absence related to COVID and non-COVID reasons, but obviously also to vacancies. I hope the report sort of sets out as well, there is a lot of recruitment activity taking place. We hear that through the Workforce and OD Committee. Steve put in the chat earlier the impact and pressure that this has placed on the Workforce and OD Directorate as well. I'm really appreciative of the support. It's one of the actions that we've put in place, obviously, to address this, is to really focus on prioritising recruitment, particularly around clinical staff, particularly. And so I hope you can see from the data that there's a lot of recruitment activity in place. It has meant as well that we have had to rely increasingly on use of temporary staffing to fill some of those shortfalls. So again, Steve's team has been absolutely excellent in supporting the position around that. So overall, the areas hopefully are no surprise to the board really. So the impact on waiting times due to some of those root cause issues, along with some increased demand for some areas of service, and an increase in activity. So specifically put some data and information there around primary care, where we have seen quite a significant rise in activity. Discussed earlier as well, obviously, that primary care has been impacted over recent weeks in terms of supporting the rollout of the booster programme. Waiting times that we've talked about in various forums at length. I'm pleased to say that there has been some recovery of the East Riding Autism Diagnosis Service position in the report. We have now secured, and it's commenced this month, some additional external provider support for that area as well. So you can see from the trajectory there that whilst it's not back on track, it is heading in the right direction, and given the capacity that we have secured, optimistic that we can get that trajectory back on plan, expected to be back on plan by the end of this month. I've touched on out-of-area placements in this report as well. We have seen recovery in November, but it has been impacted by the latest wave. Not surprisingly, when wards are impacted by outbreaks, it does mean that they're close to admission through a period, although I touched on earlier that we have made some rapid changes around our cohorting isolation arrangements to improve that position. That position, whilst our delayed transfers of care, overall are, not in a terrible position overall, but we have got some complex patients that are delayed in mental health and learning disability beds. So a lot of focus, obviously, with system partners to try and resolve those, but that ongoing position is a concern with the pressures, particularly in local authorities. So I'll pause there, Caroline, but obviously happy to pick up any questions.
Thanks very much, Lynn. Any questions or comments to Lynn, please? No?
Yeah, I've got my hand up.
Sorry, Francis.
Thanks, Chair. And thanks, Lynn. Really detailed, excellent report, which covers all the issues that we asked you to cover. So thanks for that. Couple of questions. Picking up on the sickness theme that I was talking about earlier, I was just wondering if we knew what, and I know it's something we discussed at Workforce, but I wasn't there last time, unfortunately, what the total percentages of vacancies plus sickness plus maternity. So what is the total gap in the workforce, which obviously is therefore being covered by bank and agency? Do we know that? I don't know if Steve could help with that from a workforce perspective.
Yeah, do you want me to jump in?
Yes,
Do we jump in there, Lynn? No worries. Yeah, so thanks, Francis. So we get, we report this in through the workforce committee, but we also get it from the system, which is really helpful on an almost daily basis. So earlier this week, we were looking at 17%, and that's sickness and vacancies, Francis. We know through the report that we take to workforce committee that we've got a further 2% that's maternity and adoption on top of that. So round about sort of 19% for us currently on a day-to-day basis of our roles are vacant. Or not got, or somebody off sick. So we're having to, in a lot of those cases, and particularly frontline ones, cover those roles. We know in the data that's provided to us out of the 31 provider organisations across the region, that puts us fourth with the highest rate. So I think that sort of just brings it home, the pressures that Lynn and her team are under to try and, on a day-to-day basis, with the support of my team, provide safer staffing levels and services across the patch area.
Thanks,
Thank
Stephen.
you, Steve.
And I've seen the excellent work you've done through Workforce, which is great. But it just brings home kind of 1 in 5 we're having to cover through bank and agency, and presumably we've got exactly the same problem with bank and agency. There's a lot of sickness in there as well, so it does put a lot of pressure on.
Yeah, it does. And again, Francis, just on those numbers, we've got just over 200 more staff working in the organisation now than we had 12 months ago. So actually, we've grown our workforce in the time that we're in. We've grown our workforce. Obviously, we've grown our establishment is larger as well. So we need even more people, but we've actually got more people working for us. But trying to keep up with that and keep up with demands is, as you quite rightly highlight, is a significant challenge.
Thanks very much, Steve.
Okay, my second one was around on pack page 69. You talk about it's the section around complexity of cases due to COVID, and you talk about the recruiting staff and this remote intervention, which sounds interesting and again plays to what we've been talking about in terms of digital. I just wondered if you could give us a little bit more on that.
Yes, Francis, it's very similar to Helios. But I guess to some degree it's a more senior sort of led clinical service, so it is remote. But Helios does have a threshold for complexity. This service actually has a higher threshold for complexity as well. So and obviously we took that through a robust due diligence programme as well before we secured the contract with them. So really hopeful as well that it really will have impact on some of our very long waits, certainly the over 52-week waits. So we're expecting between 40 to 50 diagnoses that they will be able to carry out each month.
Thanks, Lynn. And then my final one was on page 73, which was the primary care piece. And that really interesting table, which kind of again picks up on some of the stuff we discussed on the presentation this morning around face-to-face and etc. What would be interesting at some future time is just to understand what that was like pre-COVID, because all the information there is obviously during COVID. It would be interesting to understand how that compares to what was happening pre-COVID, because I'm sure we'll have seen some changes, and it'd just be interesting to find that out. But if you could do that at some stage, no rush, just when you get a chance, that'd be helpful.
That's absolutely fine, Francis. We have that information. Interesting, we have that information benchmarked with the national position as well, so really happy to share that.
Thanks.
Fantastic.
That's it. Thank you, Chair.
Thanks very much, Francis. Hanif.
Thank you, Chair. I just wanted to go back to those stats Steve had just read out. I'm not sure if this has been covered while I was absent, but if we correlate those to the impact or the anticipated impact come the beginning of April around leavers due to the mandatory guidance, if that's not changed by the government. Have we done any forecasting on that, Steve? Just thinking that how bad does that begin to look?
Steve?
Yeah, so we've got the figures, Hanif, are in the report for later, so cover them in more detail. But we've got a position, a kind of as-is position that of the numbers of staff that would potentially leave us on the 1st of April if they don't take up the vaccine, which without sort of jumping ahead, is 58 staff as it currently stands that haven't had the first vaccine, and a further 42 that haven't had the second. Now, obviously, we anticipate that those that have had the first are more likely to have the second, so the real number is that kind of 58. So potentially 58 staff that are in roles that need to have the vaccine are currently outstanding.
Is that okay, Hanif? We will be coming back to that later on on the agenda.
I'm anticipating there'll be an improvement as we get to April in terms of the current situation anyhow, so that might ease off some of the pressure. But yeah, we can discuss that later as we get to it. Thank you. Thanks
very much, Hanif. Peter?
Thank you, Caroline. Yeah, I thought it was a really good report, and I really like the use of the graphs. I thought that was really a good use of those. So thank you for that, Lynn. I've just got a couple of things really to do with Steve's area probably, and I just wondered if the time to recruit, has shortened, as a result of some of the work that you've been doing, Steve, in recent months. And I was also wanting to ask about retire and return, and whether the numbers of staff who are returning, having retired, is something an active area that we're looking at, and whether that has perhaps has increased because of the vacancies.
Yeah, sure. So time to recruit, we manage, particularly since we've put the track recruitment system in, Peter, over a year ago. That's given us some fantastic data. So we broadly hit all of our SLAs around that, because obviously some of those are linked to manager performance and my team's performance. So we're doing that. I think our time to recruit has come down significantly since we've had track as a result of doing it. I can provide a post meeting note about what those times are, if that's helpful. So I think the data's been really good, and Lynn picks that up in ODG as well from a kind of management point of view. So for example, we literally know the people who are waiting to start need a start date, and we can move on that. I think that's really helped. I think we've moved things through. The prioritisation point, I think, is the important one that Lynn said. So we've obviously only got limited resources in the team, and we can divert them to whatever is most helpful for Lynn. And what we've done around that is done some prioritisation, particularly those clinical roles, and within that the ones that Lynn had identified. So the team will process those first. One of the investment bids that we'll be putting in next year will be for some additional resources within that team to help move things through a little bit more quickly and provide additional capacity. So that will help, but it's more about, at the moment, it's around prioritisation for what Lynn needs and operations need is what we will divert our resources to do. And I think that's been coming through, Lynn, and working quite well, is the feedback that you've shared.
Absolutely. Close working with your team, Steve, I think has only improved through this latest pressurised period. So, and we're building on that, as you know. So,
yeah. And on the retire and return, Peter, so yeah, we encourage everybody. We contacted everybody that had left as well as part of this just before Christmas. So we've got the process. We do it anyway, but we did another push. We just wrote out and said, if you want to come back, if you want to return, even if it's just to be part of our bank, please do. And that's particularly where we can fast track people onto our books, for want of a better term, because we've already had them set up, and that's a fairly quick process to get them turned around and working and deployed. So yeah, we do that. We've written out to everybody. We continue to push and continue to try and grow the bank, and importantly, I think, grow the bank across the whole patch area, because making sure we've got people who want to work in Whitby and Scarborough is as important as people in the kind of the whole part of the world.
Thank you, Steve.
Thanks very much, Steve. I can't see any other hands up. I noticed that John said in the chat box that there is a slide that can show the impact of Omicron on testing as well. Maybe that's something that people would be of interest that can be shared later. But if there are no other questions, thanks, Lynn. And can I just say, I thought the structure of the report was really helpful, having the sort of summary of challenges and then what was actually happening. And I think the selective choice of the graphics were really helpful as well. They were very pertinent. So I really liked that it was readable, which is really important. Thanks very much. Okay, moving on then. No pressure, Pete. Performance report.
Thanks, Caroline. So this is the performance report as of the end of December. It's the usual format, and for the benefit of the viewing public, we continue to use statistical process charts and the use of upper and lower control limits to help with exception reporting. I think it's a tough act to follow with Lynn, and the previous paper's probably presented the context and has covered some of the operational performance that's within the paper. But some areas just to highlight before we move to questions, if I may, Chair. So you'll note within the safer staffing dashboard that fill rates are low, but our care hours per patient day still remain high. And obviously we've got the safer staffing report later on the agenda, and we've got a detailed narrative within the report. 3 other indicators I'll just pull out before we move to questions. So whilst it's not an exception, we continue to see high levels of training compliance for Statman, and I know Steve put in the chat box there some of the work we've done on digital access to courses, so I'm sure that's having an impact on why we've retained above our performance target. We've also seen a positive improvement in the 12-month CPA, so I know that was an area of concern and it's always an area of focus for Michelle, but great to see that performance in December is back up to 96%. And just speaking as your finance director, if you were to look at the I&E performance, you may think that's a worrying trend and a worsening trend in the first half of the year. But just to provide assurance in this report, and I know we'll cover it in the next paper, that is consistent with our ICS planning target. So I think if I can stop there, Caroline, and open it up, unless any of my exec colleagues want to draw anything else out.
Thanks very much, Pete. Just before we move on, so Jenny can note for the minutes, Francis also asked for a request to have some pre-COVID and COVID, if you like, take data in terms of contacts and face-to-face. I think that's what he was looking for. If we could just make sure that's logged on the action log to take up. Sorry there, Peter. Any questions to Peter? Dean?
Yeah, thank you, Chair. It wasn't so much a question, just a bit of context, I think, around the mandatory training overall compliance, as Pete says. Sort of good performance there at 89%, but you'll see elsewhere in the papers that we've got other references to statutory and mandatory training. So what we've got here on this chart is effectively looking at all those elements of mandatory training together that we're compliant on. And what we've been trying to do is have a look at areas, different parts of the trust where there are staff that are non-compliant in that, and then also are there particular courses that are non-compliant. So we just picked those up in other places on the agenda. So given the compliance here is so high, I just thought it was worth drawing attention to that for when we sort of bring them out in other papers.
Thanks very much, Dean. Any other comments? No. Okay. Sorry, Peter.
Sorry, I thought I'd put my hand up. Just a couple of quickies, if you may. Sorry about that. Just on the dashboard, then I was looking at the occupancy level for Millview. I think it's Millview Court, and it's 111%. I just wondered how you manage occupancy at that rate. It doesn't seem physically possible, but perhaps just explain that, how that's, why that figure is right, and what pressure that means for that unit. I was also, whilst on the same sheet, going to ask about the PQ beds at Inspire and what the likelihood is that they will now be opening fully.
Thank you, Peter.
Sorry, am I on mute? No, I'm not. So I think the fill rate piece will be to do with the clock stop and when people are discharged and admitted, but I will get a more detailed technical answer rather than go into that detail here. Lynn? You're on mute.
I suspect what's happened there, Pete, in month we increased the bed base of Millview Court again when we opened up and then closed the pod. I think it's probably a data issue. We were at no point over-occupied in that period, just for assurances.
Thank you. And on Inspire?
Sorry, on Inspire, the PQ beds, we have had pressures around current acuity of PQ of Inspire. We have recruited additional staff. The final part of the recruitment process was taking place in late December. I am hopeful, Peter, but obviously we do have to watch the acuity and obviously the enhanced nursing requirements within the units. So I think the end of February is probably realistic.
Thanks.
Is that okay, Peter? Are you happy with those answers? Okay, thank you very much. I can't see anybody else with their hands up, so if that report can just be received and noted, we'll move on to item 11, the finance report. And back to you, Pete.
Thanks, Chair. So again, this is the finance report at month 9. As I always do, just to remind the board, we continue to operate under the block funding regime, and we will continue to do so for the remainder of the year, and that our full year financial planning asked by the ICS is to deliver a break-even plan by the end of March. So as at the end of December, we had delivered a year-to-date operational surplus of about 170,000. This is a reduction on previous months, and again, I think it's just important to note at this meeting that we'll continue to see that reduction or that unwinding of the surplus as we move towards a break-even position between now and the end of March. There are a number of items in the report that don't count towards our control total. We've highlighted those, but just for completeness: depreciation on donated assets, profit on the sale of assets, and the funding flow in relation to the Yorkshire and Humber care record. So when we do include those in our ledger position, we are recording a year-to-date surplus of 3.1 million. However, that is all predominantly driven by the funding mechanism for the flow of the care record. And obviously, we are using that to fund our capital programme. Some other key highlights in the report before we move to questions are, you'll see from the papers, we are reporting a significant overspend in primary care. We did have a detailed discussion of that at the Finance and Investment Committee, and you'll see that in the Chair's log a little bit later on the agenda. And we are working on producing a recovery plan with a longer-term focus on strategic intentions. You'll note our COVID-related expenditure at the end of month 9 was 5.7 million. That is within our block allocation and fully funded. We remain in a strong cash position, and we have updated the report now to include the timing benefit from being the lead provider for specialist commission within the paper. You'll know agency spend year on year has increased, and we covered on the action log the deep dive we did at Finance and Investment Committee, and we have another planned for 6 months' time. And I guess you will pick up that our capital spend year to date is low compared to our full year plan. However, that's not dissimilar to previous years, and we often call it the hockey stick spend effect, and that's spread across the NHS. So I could go on, but I'll stop there, Caroline, and I'm happy to take any questions on the paper.
Thank you. Thanks very much, Pete. Any questions or comments? Dean?
Yeah, it's just a brief one, Pete. Thanks as always. I guess 3 quarters in, it's always a good time to ask the finance director, isn't it, is degree of confidence for the end of the year. So I know you talked about the break-even position, you've been reporting that throughout, but just without holding you too much for unexpected things that might happen between now and then, how's it looking to the year end?
I sit here today, Dean, confident that we will hit a break-even position, which is what the ICS is being asked, or what the ICS is asking of the trust. And there is, a body of noise coming out nationally that, I think there's, dare I say it, I've got to be careful how I phrase this. The Chief Finance Officer for NHS is asking trusts not to improve on their financial position in year, so asking us all to hit what our ICS planning targets are. Thank you.
Thanks very much, Pete. I cannot see anybody else's hands up. No. Thanks, Pete, for that report. That's received and noted, board, yes? Yeah, okay, fine. So we'll now move on to the Assurance Committee reports. And Dean, you're up on the Workforce and Organisation Development Committee.
Yeah, thanks, Caroline. It's they're happy to take any questions on it. Thanks, as always, to Jess and Steve's team. We had the Workforce Committee last week, and she turns this around very quickly so we can get it into these board papers so it's contemporary as possible. Just a couple of things to highlight. One of the things we did at this Workforce Committee, because we set the agenda sort of prior to Christmas and commissioned the papers, we were mindful that the Omicron wave had hit, and also the legislation on VCOD had, the vaccination as a condition of deployment had been passed. So we thought it was useful just to allow John and Lynn and Steve just to highlight any sort of particular issues that were pertinent to their operational challenges at the time and anything that the committee should be aware of or could help and support with. So we did some of that at the start of the meeting, and then just a couple of other things to highlight. I think we had reports from the assurance committees and got some updates in terms of EDI and the appointments of network chairs in there, which was really welcomed. We'd done deep dives, is a way that we've approached things into this committee, that where we're looking for different sorts of levels of information to seek that sort of assurance. And one of the things we'd done previously was about statutory and mandatory training. So this refers to my comments in the performance report, really, where you can see that overall the trust is compliant in terms of its target around this, and in fact exceeds that. But we're mindful that there are some categories of statutory and mandatory training which don't achieve that target. That's not to say that people haven't had any training at all. It's just that they're out of date. And what we'd asked for is a trajectory about when those would come back in. So some work being done in terms of looking about the people that should be in scope around those to give us that sort of assurances of when those will be achieving compliance. So it was helpful to receive that. And then the other thing that we did is just in terms of looking at the risk register, we're mindful that we've carried some risk for some time, like many organisations, around sorts of workforce, and we've constantly refined those along the way. And we just asked the executive team that in the context of the Omicron wave, increased absence, a sort of sense of the health and well-being of staff going forward, and the vaccinations as a condition of deployment, is whether that was all captured appropriately there, or whether it needed a different risk sort of identifying. So we just thought it was important to ask the exec to go away and have a look at that. And then the hard to fill recruitment work was helpful. And as Steve had reported earlier, really, it's good to see that despite that we have got a level of vacancies, the workforce is continuing to grow. And we've got a sort of glide path in for those that we know are in training, sort of international recruitment, people that are doing apprenticeships and converting, etc., to help with that. So we're keeping a focus in that area. But happy to take any questions, Chair.
Thanks very much, Dean, and it's great to have the turnaround, hot off the press. Any questions or comments for Dean? Hilary.
Just to add to Dean's update there around the deep dive, one of the areas was safeguarding level 3, wasn't it, Dean, that the committee asked for information on. So the head of safeguarding came and gave an update with a lot of work being done around that training. You asked that the quality committee look at it as well. So there is an update going to next week's quality committee, because obviously that work's moved on a little bit since we presented it to the workforce committee. So we are at the moment on track to have a trajectory in place, good to go for the new financial year. So the 1st of April, we should have that trajectory there.
Thanks very much, Hilary. Anybody else? No? Okay, thank you, Dean, for that comprehensive report. We now move on to item 13, Humber, Coast and Vale Specialised Mental Health Learning Disability and Autism Provider Collaborative. And Peter, you're leading on this, please.
Yeah, thank you, Caroline, and well said. It's quite a mouthful, isn't it? Yeah, we had two meetings. We had a full meeting on the 30th of November. And then we had a smaller meeting just before Christmas on the 21st December, just to discuss certain quality issues. So that the reports are there. I'll take most items as read, but just to highlight maybe some of the points there. So on finance, there are no outstanding queries with NHS England, and the monies are now flowing from ourselves, through to ourselves, and then through to subcontractors. Providers as necessary. It seems to be working well. On quality, we were tasked with doing the safe and wellbeing reviews on 29 patients, with quite a short turnaround by 29th or by the end of January 2022. So we had an initial meeting in November and then a follow-up meeting in December. And pleased to report that all those reviews should be complete. I think there's just 2 outstanding, but they will be complete by the 29th by the 31st of January, sorry, and that all the actions will have been completed that NHSE require. On quality data, we've done a lot of work on the quality dashboard, working very closely with the other providers in the collaborative, and there's a very good working relationship coming through there, and including more recently visits by our quality manager to Stockton Hall, which is one of the providers, and they were very cooperative with that visit, discussed things like the COVID outbreak and the capital works that they have got coming up, and various other quality issues. So it seems to be working well, and it works well from both sides. Just on the work streams, CAMS, it's going well. There's reduction in outside natural clinical flow is working. What I would say on CAMS though is that there is more demand, and the more recent meeting did highlight a demand in CAMS inpatients, which is one of the reasons why I asked about Inspire, because I think the last figure I heard was there was 9 young people waiting for an inpatient bed in the area, and the safety of those 9 young people is being closely managed, but still there is this waiting list that has built up for CAMS inpatient within the area, so I'll just highlight that to the board. Nothing to report really on adult eating disorder, and on adult secure I mentioned about Stockton Hall, but there's been a very good reduction in the out of area natural clinical flow to 33%. So that's an area that we're keen to look on to reduce the number of patients who are outside of the area. There was an issue with delayed transfers of care. There were 9. I think that's come down slightly since, but it's also been closely managed. Subcontract meetings, I think elsewhere on the agenda we've got a discussion on some of the contracting relating to this area, so I won't take up the time here. I think that's probably about it. Yeah, I'll say that was it, Caroline. Thank you.
Thanks very much, Peter, for that comprehensive report. Any comments or questions to Peter? No? Thank you. So that's received and noted. Okay. Moving then on to the Finance Investments Committee assurance reports, which also includes one that has reporting from a January meeting. So congratulations there, Francis, as well, and to whoever put this together for our attention today. Francis, over to you.
Thanks, Caroline. Yeah, very contemporary. It was last Wednesday. So yes, there's been 2 meetings, one in December and one in January as we move to the new quarterly approach. I'm not going to dwell too much on the December one, but I will pick 2 things out. Before I do that, I'm not going to go into detail on the financial piece because we've had financial from Pete, and as a committee we got good assurance in terms of the financial position in both meetings and picked up what Dean had asked the question about earlier. And I will talk a little bit about that, Dean. So from the December one, the 2 things I would pick out are the deep dive on agency expenditure. So we had a detailed report on what was happening on agency expenditure and the roles that were up for advert, and it was a very good discussion. I'll bring Pete in at the end, but we did talk about VAT within that and how we might be able to look at how we use agencies from a VAT perspective. And the other thing that we talked about was the Trust Green Plan, which needed submitting to the ICS, and we received that and signed it off. And I can report that it has now been submitted. I think Pete will confirm that to the ICS. If we then move to the January one from last week, as I said, we heard a detailed financial update from Pete, but the area we focused on specifically was primary care, where there's a deteriorating financial performance, which is an issue. And we've asked for a detailed recovery plan that didn't have a negative impact on patient care to come back to the committee, and then a longer term strategic review from a financial perspective to understand how that might impact going forward into next year. We gained assurance on the capital programme, as Pete said, the hockey stick approach, but we did see what was planned for the rest of this year. We received some excellent work on developing a draft budget and the BRS to support it for next year. And as FIC now has gone to quarterly, this will be developed further through the board, because obviously there won't be a FIC now before the start of the new year. So further iterations of the draft budget will come to board in February and in March. We had a look at the 5-year estate strategy and reviewed our achievements against that over the last 4 years, because it runs out at the end of this year, and complimented the team on some excellent work. And the new 5-year strategy will come to FIC in September, because it needs to flow from the work that's ongoing on the strategy refresh. And we had an excellent presentation from Lee Rickles on the Yorkshire Care, Humber and Care record, gained assurance on the Trust's management of that. It was more about how we were internally managing that process, but we had a great update on it and complimented the team on their success to date. And I think those are the key issues. I don't know if Pete wants to add anything to that.
Thanks, Francis. I guess the only one I'd add, and I just noticed my camera's frozen, so I'll fix that in a minute, is that the annual accounts timetable and the fact that this deadline for submission is the 22nd of June. So I know an email has gone around board members to look at actually bringing the board meeting forward a week to enable that to happen. Just in some of the points you've raised very quickly, Francis, and then I'll probably bring Steve in to support me on the consultant VAT piece of work, is the green plan's been submitted to the ICS, and obviously the ICS plan gets submitted by the end of March. Obviously, our draft plan will continue to work on it, and it'll get nudged and refined as the guidance progresses. I think we're all sat waiting for the detailed analysis to come out so we can start to put some of the numbers in. And on the consultant VAT expenditure, I think one of the areas we talked about when we did the deep dive was to look at how we could maybe look at mitigating or reducing that spend. And I know, Steve, we've had a quick chat, haven't we? I don't know if you want to come in on the plan we've got in terms of resourcing the project.
Steve?
Yeah, thanks, Pete. Yeah, good news hot off the press, Francis, around that. It looks like we've identified someone on a short-term contract who will be able to come in and do that piece of work, which is great. So they're going to come in and focus on seeing how we can try and make best use of the system that Pete has talked about and identified, but also do some really positive work around trying to recruit consultants into the organisation as well. So good news all around, I think, on that one.
Thanks, everybody. Thanks for your updates.
Thanks very much, Francis, Pete, Steve, for that. Any questions at all? John?
So, Francis, you mentioned a further review of cost expenditure in primary care, and I'm reassured to hear that you're thinking about potential quality impacts on that. I'm just wondering, based on your experience, where you think this may lead us with regard to the strategy review that's ongoing at the moment, or is it too early to say from your perspective?
I think it's too early from my perspective, John. We had a good discussion on it, and we fully understand the issue of the lack of GPs and the shortage that is a national shortage. And we also looked at there's a couple of practices that we've got that are where 2 GPs are looking to retire fairly shortly, which is going to put more pressure on. So it is one of those wicked problems. I don't know how we go about solving it. I know it's a key issue for the team, and we want to be absolutely guaranteed that patient quality and the service we provide is the right service. So it's a balancing act. I don't know if you've got anything you want to add to that, John.
Michelle has got her hand up, I think.
Yeah, no, I mean, obviously it's not necessarily finance, but picking the point up, it's a good question, John. I mean, obviously that will be part of the recovery plans that we asked for at FIC. But one of the things from a system point of view is, I'm leading the ICS provider collaborative design piece. But one of the things I've asked the primary care collaborative, because we've got 4 collaboratives, one of which is the primary care one, as you're aware of, is what they can and what is the art of the possible in relationship to provider collaboration vis-a-vis primary care GPs, etc. So we're doing it through that route as well, rather than the internal piece. I don't think it does need to link to the strategy, but it's a system-wide piece as well that we've asked for. So we'll wait and see where that takes us. So just a bit of reassurance that we're talking about it in the system.
Okay, thank you. John, did you want to come back on anything like that?
No, I think it's just helpful, just that, Francis, you recognise that wicked problem, so to speak. where there's the national issue with regard to recruitment, which isn't going to be fixed anytime soon. And that leaves ourselves in a position of providing care to patients in very vulnerable areas too. And that's one of the things we have to counter in terms of health inequalities, because we're not necessarily operating in areas of high welfare stuff. So that's one of those things for us to think about. So yeah, happy to hear that you're focusing on equality from that point of view.
Thank you, John. I can't see any other hands up, so I think we can. I just want to say that I think, you know, all the assurance reports, it's really good to see actually that they reflect actually some of the issues and areas that for priority that we discussed earlier in the meeting, and that the committees are onto it and seeking more assurance in those areas. So it's good to see that synergy in play. Thank you very much for all those reports. Thank you, Francis. Moving then on to the 6-month review of safer staffing. We have Tracy Flanagan with us. Tracy has been waiting very patiently, and Catherine Hart as well, for another item on the agenda. And this is a review of safer pet staffing in our inpatient units from April 21 to September 2021. Now, Hilary, I know you're the lead. Would you like Tracy to go in and then you maybe follow up? Or did you want to do an introduction?
No, let Tracy, so I don't steal any of her thunder. Let Tracy go.
I knew you would appreciate that. So Tracy, very much welcome to the board today, and apologies for keeping you waiting, but we're really looking forward to hearing from you.
Thank you, Chair, and it's good to be here. So yeah, the Safe Staffing Report from April 2021 to September 2021. This is the 6-monthly report that comes to board, and this is the second report that has come since we've reinstated the local reviews with teams and the use of the evidence-based tools to collect dependency data to help inform those reviews. The roster team has also been involved in these most recent reviews, and that's allowed us to make some adjustments to the demand template, which have an impact on our fill rates, which I'll come to in a little bit. As you can see, the board does provide, the report does provide good assurance that our staffing levels are safe, and I think in the context of the year we've had, that's really impressive. And we've come to that based on the outcome of the reviews and the triangulation of the quality and performance data, which we review monthly, but also benchmarking our data on care hour per patient day through the model health system, but also we have some of that data available to us through the MHOS tool, which is the evidence-based tool for mental health optimum safer staffing. So we can see that 4 areas of providing adequate assurance that they're safely staffed, and 14 areas, so the majority, providing good assurance. It's the second reporting period that Town and Court and Inspire have been providing adequate assurance. But when we've done their most recent reviews, we can see that that is in relation to their fill rates. Town and Court has had low bed occupancy for a prolonged period of time. That will change in this next reporting period, but it had dropped again in the period between April and September to just below 50%. And that does have an impact in terms of their fill rates and their care hour per patient day. So although their fill rates look low, their care hour per patient day is strong. And that is the most reliable and useful indicator for us, I think. But also their demand template is being adjusted because what the demand template was looking for was more registered nurses than are currently required to maintain their safer staffing levels. And similarly with Inspire, their fill rates have been low, but this is because they've been looking for 2 registered nurses on days on the PQ unit, and as you will be aware, the PQ unit only has 1 bed open currently. So that skews, they don't need 2 registered nurses every shift, but the demand template is looking for that because that's what the minimum safe staffing will be once they are fully operational. And we've had recent reviews with the team at Inspire to look at what that demand template needs to look like once Nova becomes fully operational. But similarly with Inspire, their care hour per patient day remains strong and benchmarks well. Generally, for all the other units, care hour per patient day remains above the trust target. We adjusted the target for Pine, View and Ouse to reflect the nature of their patient population, so they're now above target as well. And going forward, we've now got more granular detail from the model health system, which allows us to look at the care hour per patient day, both regionally and nationally, for more specialist types of ward. So we will be able to set those targets more specifically going forward. We also, as part of the e-roster team being with us in the review process this time, have looked at how we can capture allied health professional care hour per patient day contribution. And this has been a bit of a vexed issue for us. We've had allied health professionals working on the wards and we haven't been able to capture the contribution that they make to safe staffing through the care hour per patient day reporting. But what we've agreed, having reviewed this in more detail this time, is that actually maybe the best way to capture the contribution that they make is what some of the tools call the ready for action provision of staff that are available who might not be deployed in the minimum staffing numbers, but who are available on the ward to provide those activities that support safer staffing to be available if there was a situation that required additional staffing. Regionally and nationally, we're still performing above our peers regionally and nationally in terms of care hour per patient day, and that's across registered nursing and our healthcare support workers. Sickness remains a challenge, as we would have expected, I guess, but has improved slightly overall within the reporting period, and that can be seen as being attributable to COVID-19 absence and some long-term sickness. Vacancies have as well increased across all of the teams in general, but there's ongoing work around the How to Recruit plan, including the international recruitment, has meant that we have now, for example, on Malton, deployed 5 international recruits to Malton who did have a significant rise in their vacancies during the period. So that hopefully will continue to improve going forward. And we've been successful in both the introduction of the professional nurse advocate role, and we've been successful in a bid to hopefully have 2 professional nurse educators roles, which will really help us to focus on retention. So hopefully, we will continue to see that improvement in the vacancy position. Training PADR remain relatively stable, a little drop in supervision, but that is managed locally on a monthly basis following the quality dashboard review and through the accountability reviews, but remains around target. In terms of next steps, care hour per patient day pilot is being proposed for Maister, and this will be to look at how we use some of the new roles that we've introduced and how we ensure that they're reflected in the minimum safer staffing levels on the unit. So instead of routinely looking for 2 first-level registered nurses, that we actually start to recognise that often there's a second registered practitioner on shift who might be a nursing associate, or it might be a pharmacy technician or an OT. And so we'll actually change the demand template to reflect that. So that will hopefully show an improvement both in our RM fill rates, but also in our care hour per patient day. Continue with the rolling programme around the reviews, and as I've said, we'll do the review of the local care hour per patient day targets, and with a continued focus on the How to Recruit plan and again that retention piece with the support of the new professional nurse advocate and nurse educator roles. I'll stop there. Happy to take questions.
Thanks very much, Tracy. So, Hilary, did you want to add anything before we just open to questions?
Just very quickly, really important paper. It's a nationally mandated paper following the mid-staffs incident all those years ago, where we look at the 6 months. And certainly for me, it gives a lot of assurance around we are safely staffed. So the CHPPD is above the national, there's quality indicators looking good, and the board look at this every month anyway, don't we, through the safer staffing dashboard, so there shouldn't be any surprises in there, but this just brings it all together and triangulates it as well with other indicators.
Thanks very much, Hilary. That's helpful addition. Hanif, I can see, and then Michelle. Hanif first. Hanif? Hanif, you're on mute.
Sorry, I've only been doing this for 21 months, so I'm getting the hang of it. But
don't worry, it happens to the best of us.
Just a quick point of clarification in view of the the part of the report around recruitment, in particular nurses. Is there a reason why we limit the international recruitment target to 20 nurses?
That's an interesting question. I think we worked with a collaborative that was overseen by the NHS England, and they were involved in setting the targets for us all organisationally. I think in order to make sure that we really give a good experience to our international recruits and make sure that we've got the resource available to support them to get through their OSCEs, that's really important, and to support them to integrate them onto the wards once they've got their PIN numbers. We didn't want to overstretch ourselves. And also, absolutely critical is the pastoral support that we can provide to them. So we've focused on, I guess, quality over quantity, but we continue to be really ambitious around the numbers that we want to continue to pull through, and we've got that pipeline in place. So we're learning with every new cohort. We're on to our third cohort now. So we're learning with every cohort, and certainly. You know, we're already seeing the early signs that those international recruits are talking to their colleagues back home and saying that they've had a good experience, and that's probably the best way that we go forward in terms of ensuring that pipeline of people that want to come because they know it's a good place to come to work.
Thanks, Tracy.
Thank you.
Michelle, and then Peter.
Yes, thanks for a good report. And obviously we discussed this in detail at the executive management team, so I won't go over the questions that we asked there. But just obviously important to think to all of us is what you mentioned about care hours per person per day. So it's really great that we're maintaining that and exceeding it in some areas, but maintaining it because we've always been a really high performer, and that's really positive. And again, I thank staff for that. That's really key. I think this does help the conversations that we've been having about workforce, that you know, obviously we continue with our recruitment, retention piece, but I think this just gives us a bit of assurance that even with that backdrop that we are delivering a safe service. I do think it's important to do what you said in relationship to the templates, in relation to the wider skill mix and skill base, because we talk a lot about, especially in our services where we need different skill bases, we need different modalities of care, that it's really important that we actually collect that and link the two together. So I think that's really important. I look forward to seeing how that develops. And also what I do appreciate with this, I think I've mentioned before, because obviously I do like the benchmarking piece all the way through things, which is good with developing the insight reports along those bases. But obviously the triangulation with the incidents, I think the more we can triangulate this report with our other quality reports, the more it's meaningful now, but the more substance it has. So please continue to triangulate it as much as you can with instance and all the other plethora of metrics that we use. But good report, Tracy, thank you. I know it's a lot of work, but really great to see that we're still maintaining that care hours per person per day.
Thank you, Michelle. I think just to comment on that, one of the things that has restricted us previously around how we report locally on our care hour per patient day is the national reporting requirement. So it has been kept very separate, and how we could report AHP hours and nursing associate hours has been tricky, I guess, to navigate. And I think you can see that in the regional and national reporting, that there isn't a lot of AHP care hour per patient day being reported. So we're hopeful that we can now start to capture that a little bit different locally, and yes, certainly reflect the richness and the breadth that we've got from some of the new roles that we've introduced, and the very real contribution that they do make to safer staffing. It's important to acknowledge. Thank you.
Thanks, Tracy. Peter.
Oh, yeah, thanks, Caroline. Thanks, Tracy. Yeah, that's a very thorough report. Thank you very much. I want to ask a question on Maester, because you mentioned about the pilot scheme that you're doing there with splitting out the role into one registered nurse and one second registered practitioner. I'm just wondered how that tied in with the fact that Maester has recently increased its bed base by 5 beds, and whether that was still appropriate to do that pilot on that basis. You know, how has that been considered from a safer staffing point of view?
So the Maester Lodge would be where the focus of that work would be, that pilot, and their establishment is separate from the establishment for Maester Court and Millview Court. So it would be looking at that team that's already established with new roles, including pharmacy technicians and nursing associates, and working with them. But I guess we would proceed really cautiously, and we'd look at doing, before we made any changes, we'd want to look at putting it through a QIA approach and making sure that we've really understood what any of the risks might be. But I am very confident that Maister Lodge has done some really good work with these new roles. They are working shifts, which they're not in other areas necessarily. So they're sort of a little bit ahead of the curve. So I think it would be good if we can look at that pilot, and then it does allow us to test some of that, some of the issues around quality and safety before we look at rolling that out more widely.
Thanks, Tracy.
Thanks, Peter. Anybody else? Tracy, I just had one question, if I may. I mean, Peter actually just picked up in an earlier item about beds available at, for example, Inspire and the demand that is there. And I notice, obviously, from the report, one of the things you say is that areas with lower fill rates are still providing good care hours per person per day, and that's partly due to reduced bed occupancy. Now, given obviously we want to make sure our beds, as and when we can, are being fully occupied and providing that service, are you looking at, in terms of, you know, where we get to that point, how we're going to actually manage it then? Because obviously some of the things that are positive are partly seem to be due to that low bed occupancy.
Yeah, no, absolutely. And this is where the tools are really critical, because they allow us to look at both the acuity and the level of dependency of the individual service users that we've got on the ward at any one time. So that's reviewed on a 24-hour basis when we do the data collection. But it also looks at the number of service users we've got and the ratio of staff, both registered and unregistered staff, to each service user. So for example, with Inspire, as we're looking at sort of opening more of the beds in Inspire, I've done work with the team to do that modelling using the tools. So to look at what their current dependency levels are, and then that allows us to the tool gives you a recommended number of care hour per patient day and numbers of staff on each shift. We then discuss that in the round with that sort of triangulation of some of their performance data to come to a professional judgment about what the minimum staffing levels should be. And I guess the using the 6 monthly reviews, but also you can use the tool at any point to look at what any changes to your bed occupancy or the acuity of your patient population, how you then might need to adjust your staffing numbers and your staffing establishment to reflect that. So Inspire, for example, have been doing a lot of work. They've collated the dependency data for both Nova and for Orion, and we've been scrutinising that to look what that would mean if they were to increase their bed occupancy. So the tools are critical in that, and it is, yes, absolutely. We don't want to rely on low bed occupancy to give us a good care hour per patient day and other sort of outcome indicators. We need to be flexible and fluid in terms of how we adjust the staffing levels to reflect changing bed occupancies. And through COVID, we've definitely seen some changes in how people are presenting in our units and the levels of acuity that they're presenting with. So the tool picks that up as well. Yeah.
Thanks very much for clarifying that for me and how you're going about it. Thanks very much. Any more questions or comments to Tracy? No, thank you very much, Tracy, for a really full report and clear report, and for your answers today. Thanks very much.
Thanks, Chair.
Okay, moving on to item 16, we have Catherine Hart here, Assistant Director, Research and Development. And again, my apologies, Catherine, for keeping you waiting for quite some time. Hopefully, is it okay if we go the same way and just let Catherine do a presentation, and then John, you might come in afterwards and add a few comments? Is that okay? Brilliant. Catherine, over to you.
Thanks, Caroline. It's actually been really useful listening in, because I can see how research really links clearly into the offer for the trust, whether that be workforce and weaving research into new posts and making them attractive, looking at the effectiveness of our ward-based pharmacy, which is something that we're developing a project on at the moment, or increasing the offer for patients in primary care. So actually, it's been really helpful for me. And I think some of the things that I've brought out in the report maybe kind of weave into some of those things. So I won't pick out too many things, because hopefully you've managed to read it. This year, there was less focus on our individual performance as a trust in terms of things like recruitment targets to clinical trials. But interestingly, regionally, we were the highest performing region across the country in terms of recruiting people into COVID studies, including vaccine trials. So as a Yorkshire and Humber region, we've been fantastic, and as a trust, we've contributed to some of that. There's also a new target this past year for 45% of GP practices to be research active. And as a result of getting some extra funding to introduce a research nurse for primary care and a bit of funding for one of our GPs, we've actually managed to get the majority of our practices now engaged in research in some way. So I think at the moment, maybe 6 out of 8 are engaged in research in some form or another. And actually, we've got a bit further down the report, I mentioned a new study called Panoramic, which is a massive national study looking at antivirals for COVID in the community to help prevent COVID becoming so severe that you end up in hospital. So catching those with COVID in the community and prescribing antivirals. So we're about to open that study as a hub across all of our GP practices. So that's really fantastic that our practices, having gone from no research, are now going to be engaged in a massive national trial of new drugs. And interestingly, over the past 6 months, there has been so much out nationally, which is supporting research. I think COVID has catapulted research. It's always been important, but I think now now the public can see its importance as well. So we've got things like the Chief Nursing Officer's strategy for research. We've got a new strategy out from the CQC. We've got, I think the Chancellor, it was £5 billion of extra research funding. We don't know how that's going to feed down to the regions and then down to trust. But I think everything nationally is looking at the importance of research. So that's really good for us. And it mirrors our strategy. So a lot of the things that are coming out nationally are saying the things that we've said in our research strategy around trying to make sure that we offer research to everybody that comes through our door. And at the moment, we're looking into how we do that much more easily amongst our clinicians. So maybe getting that onto Lorenzo and onto clinical paperwork as standard. So it just becomes part of normal practice and it's not a difficult thing for everybody to do. So that's something we're looking at as well. We've done things like, some of you came to the conference last year. We're just trying to sort out a date for this year's conference in November. It might not be the date that circulated yesterday, but sometime in November, we're going to get a date for that conference. And the feedback from this year's was fantastic. Everybody wanted it virtual and face-to-face again. And hopefully this year we can welcome more people to the venue as well. We're opening new studies in so many new areas. So as well as primary care, we're also opening studies in our community services. We've just opened a trial around catheters. I won't go into the details of that. But we've got all sorts of different things going on. In Market Wheaton practice this week, we just opened a study called Active Brains, and we've already recruited 7 people into that practice. We've had a fantastic response from that area. We've linked in with the PPG there and have already identified some research champions that want to get more involved in research. So I think a really good example of how research can increase the offer to our patients. What else is going on? We've also developed some tools to make introducing research easier. So last year we developed an animation that we can play to patients, service users and carers. It was co-produced. We've now developed that further so that we've got subtitles on that animation, and we're going to develop new characters and different languages. So we're actually talking to some community groups, community BAME groups, various people across the patch to see how we can develop that further. So I won't go on, but there's lots of really, really good stuff. It's been an incredibly busy year, and I think it will continue to be because the profile of research has been raised massively the past 2 years. Thank you.
Thanks very much, Catherine. And having attended both days of the research conference, it was really great to see the diversity and actually sort of expanding maybe people thought research was all about and how they could actually put a project together. So you might be hearing from someone I met recently who's a new member of staff in social work, who I met at the recent Welcome to Humber event, who I did point in your direction. So I might send you an email about that, because she had some ideas about what she'd like to do as well. So it's really great that there's that sort of opportunity for people to come up with ideas. So thanks very much. Any question, Francis?
Just want to say, fantastic. It really is to see the level of research, and again, get my teeth in. Another great report, Catherine. Really, really excellent. I had 3 questions, and you've kind of answered 2 of them. The first 2 were around the research with GPs and the trial, which both look really good to see that. That's excellent work from you and the team getting there. I don't know if you want to add anything to that. And the third one was around the conference, which I agree was excellent, really, really good. I just wondered how the numbers compared to last year and the previous year in terms of attendees for that. So one was around the GP research and the other was around the conference, but both really excellent. So well done.
Yeah, in terms of the GP research, I think it's been incredible the difference it's made having a GP identified as a research lead, and just a bit of funding for a research nurse that can link in with the practices and actually go and physically be in the practices if required and do a lot of the work that maybe traditionally researchers expected the practices to do. So just having that little bit of funding to pump prime, it's now developing more interest from some of the clinicians working in the practices to get more involved, but it also ultimately brings in more funding, which is brilliant. The more research we get, the more funding we get, and it just catapults it. In terms of the conference, we had a few more registered this year. I think last year we maybe had around 300. This time we had about 340. So it is growing year on year. My problem now is how to beat the speakers and the format that we had last year. So yeah, it's brilliant. I'm just really chuffed with the way the past year has gone.
Nice challenge to have when you're recruiting such top-class speakers that you're then struggling to get somebody better the following year around. Nice problem to have, that, Catherine.
Absolutely, absolutely. Michelle?
Yeah, obviously my declaration of interest is in my declaration list, but obviously I do chair the research network for Yorkshire and Humber, and it would be remiss of me not to say that we do punch above our weight in relationship to research, and that's down to Catherine's leadership. Yeah, and it is great to know that we've really seized the opportunity, particularly in the primary care piece, because some of the results are outstanding even in a really short period of time. And as you know, it's something that we have to continue to increase and develop as an organisation, because we've been spending a lot of time talking about service users, care, staffing, all this links together, and I do think we need to do more. And maybe this is a question, probably. We do need to do more in relationship to recruitment and letting people know just how much research we do and how much we're high performing in research, because I think sometimes that might bring people into the organisation. So I think we probably just need to up that element of our research campaign. But great stuff as usual, Catherine.
Okay. Thanks, Michelle. Anybody else? John?
So just to, Michelle, you're right in promoting the research work, and we do a lot of stuff now on LinkedIn promoting the work of the research team, which is very positive and does attract, dare I say, some high caliber interests, and it's a slow build over time. So that's great to see. Chair, we're always looking for the golden thread. So I just want to sort of point out 3 things here. At the start of this morning, we talked in detail about the importance of patient experience and patient and feedback through the community survey report, and how we need to go a little bit deeper in that. For those of you who are eagle-eyed and had a look at the Chief Exec's update, you would have seen that I did an update on patient and care experience around a research project which we are participating in with Imperial College, which is based on scale, spread and embed. And what we are doing with that research program is working with Imperial to look at all the friends and family test data that we get, whether it's in primary care or perhaps in our mental health services, and they'll be applying a digital or a technology approach to assessing that huge amount of feedback which we get but don't normally have the opportunity to interpret. So if we bring those 2 things and then we talk about our research strategy, which Francis, you played a key role in promoting us to be a little bit more ambitious 18 months or 2 years ago, you can see how our research strategy is now much broader at this point in time than perhaps it was 3 or 4 years ago. So if we're looking to sort of think about how the organisation has developed in terms of patient care experience, in terms of working with research, and in terms of doing some digital stuff, I think you just see that obvious golden thread this morning. I think sometimes it's difficult for us to see it ourselves in terms of joining the dots, but a lot of that is fundamentally based on the hard work of people like Catherine, but also the fact that people like Mandy Dole, who was on the call earlier, are now working together. So we've got that sort of closer corporate and clinical working together. So it's much easier to get things like research, which has a positive patient benefit, up and running right across the trust. There ended the lecture.
I think that's a really important mate. Is how do we capture the connections between different parts, different work we do within the trust, and how the research plays into some of those areas of improved patient experience. And I'm sure the EMT will look at making sure that we can join that up in some way, and maybe make that always conscious to make that visible where change has come from, especially whether it's come from research within our own organisation. I think that's a really important point. Catherine, there's no other hands up. Is there anything finally you'd like to say? I mean, obviously people are really supportive of the work.
Chair, can I say one last thing? The other thing I would say, which Catherine and John have done an excellent piece of work on, is not only have they broadened it, but it also now makes a contribution, because when I first joined it didn't. And now not only does it contribute from a patient experience perspective, but also from a financial perspective. You wouldn't want me not to say that, John.
No, there says the chair of the Finance Investment Committee. Yes, absolutely. I always like to think if you can sort of have 2 wins rather than just one, that's even better. So, Catherine, final words to you.
I suppose just it's a thank you just for everybody being supportive. I think coming to the board for the past few years, which I didn't used to do, has also raised the profile and helped me feel more supportive and probably braver to do things, actually. So that's been great as well. So thank you.
Thanks, Catherine. Have a good week. Thanks for being with us today.
Thank you.
Great. Annual declarations report. Pete.
Thanks, Chair. I'll try and rattle through this as quick as I can. So, as part of the year-end process, the Trust are required to make a number of annual declarations. There are 3, which we've included in the paper. So, firstly, we need to certify that we comply with the conditions of our provider licence. There's a body of evidence in Appendix A, which I'm happy for anybody to provide anything further if you think we've missed anything. Within that, we also declare 2 conditions which are in our licence. One is we're registered with the CQC, which we are, and one is that directors and governors meet the fit and proper persons test, which we do annually as part of our year-end process. So we're compliant with both of those. The second condition is about having good governance standards, and again, in Appendix B, we provide evidence against each of the statements for good governance. And the third condition relates to Commissioner-requested services or essential services, about us being able to demonstrate our ability to continue to meet that obligation. Again, we've put some evidence in Appendix A, but also as part of the year-end process, we undertake a going concern assessment. And again, that will be part of this year's annual accounts process. If I can pull 2 other points out, if I may, and then happy to move into questions. Firstly, we also make a statement on equipping governors to fulfil their role. And again, we've put some evidence for that within the report. And just secondly, as part of this year's audit programme, we have commissioned some dedicated audit days just to look at our process and how we report it. So next steps will be to take this report to governors in April, so we can ensure we've got their views taken on board, and then we bring a final version of this report to the Trust Board in May or June as part of our annual accounts and annual reports process. So I'll stop there. Happy to take any questions.
Thanks very much, Pete. I see Dean.
Thanks, Pete. I know this is one of those sort of technical things, isn't it, where we have to sort of approve and sign off sort of each year. But just in terms of your comments about other areas to include, just on the appendix in pack page 190, under C2, the competition oversight, I just wondered if it was worth there in terms of the comments, putting something about the way we've put the governance around the collaborative. So be mindful of that, the legal advice that we took, etc., about setting that up so that we were compliant in that regard, given the potential conflicts around that particular thing. And clearly we've got Peter chairing that. And then also at 194, So paragraphs 4 and 5 under the statements about the board being satisfied. I wonder whether we just ought to put something saying the constraints on being satisfied given COVID and our inability to be as visible within the organisation in terms of that oversight that would normally comply, we ought to reflect upon. And likewise in number 5, whether we ought to again capture the sort of COVID constraints on that. So although we've done lots to sort of overcome that, we have been somewhat constrained by doing this. And this relates to my point earlier about, as we come back into, normal ways of working and Plan B, getting back into that board-to-ward type visits, I think is going to be important in terms of demonstrating the compliance in that area.
Yeah, good point, Steve. Happy to take all those on board. Thank you.
Thanks very much, Pete. Peter.
Yeah, good points from Dean there. I just think in some of the sources for evidence, but when we get there on things like number 2 there, we might want to include, as well as the board performance reports, etc., we might want to refer to the governance review, which I think probably will have been concluded by the time we get to the April Council of Governors meeting. It might be quite a useful document to include. And more generally, I think this licence seems to very much relate to us as a provider. And I just wondered if there was anything different by the fact that we are sort of a commissioner as well, whether that makes any changes to it. I know Dean mentioned it there in terms of the Chinese rules, etc. But in more generally, are there any more requirements for us to satisfy here?
I guess my answer to that, Peter, I think your points are well made, in terms of the well-led review. I think we are a lead provider who commission services, so it is still a provider licence. It's just that we're now commissioning more under that lead provider approach than we were perhaps pre-lead provider, because we still commission services then, didn't we?
Yeah, that's fine. Thanks, Pete.
Okay, thank you. Just in terms of the part of the annual declaration in relation to governors and support and training, we've had a discussion around this at Council of Governors before, and we had a specific discussion around this at a governor development session. So there are some different ideas already in train. So we want to make sure that that's reflected in the report back as well going forward, Pete.
Yeah, I guess what I would say, Caroline, if anybody can think of any additional evidence, because this has been an iterative process before, just contact me and we'll weave it into the report for the one that goes to governors and then to board in May, June time.
Thanks very much, Pete. Okay, there are no other hands up. Thank you for that, Pete, and you'll take on board some of the changes colleagues have said in terms of the report and what it's reflect. Thank you very much. Okay, moving on then to the Council of Governors meeting of the 7th of October. We've had another one just in January. It was a full meeting and a full agenda to discuss. And, part of it was the report backs from the Governor support committees as well, which I think have all been working really well. And we'll be obviously, as I said earlier, reviewing the membership of those to make sure that we can continue the input that they have and the opportunity for governors to explore in a different way what the work of the trust is all about. So any comments on the minutes of the Council of Governors meeting? Nope. Okay, we'll receive and note those. Thank you very much, colleagues. And we move on now to John and the Health and Equalities and Approach in Humber Teaching NHS FT report. Thank you, John. Over to you.
So thank you, Chair. So it's a short paper. I'll take it as read that most people have read the paper, but I just want to capture what the essence of it is. One, it's a definition of health inequality. So just so we're clear what we're talking about, because it can mean different things to different people. I think it was just important just to reflect the key national and regional policy documents. I am mindful that now that everyone is talking about health inequalities, Build Back Better, sort of the whole levelling up agenda. But actually, for people who've been in and around health and social care for the last 20, 30 years, you'll be familiar with work about the Marmont Report. You'll be familiar with the concept of public health. And this isn't a new agenda for those of us who've been working at it. However, I think it's fair to say that there's a renewed focus on this in terms of health inequalities and our role in that. What I've done in this report is also captured what I think is the way ahead in terms of how we think about health inequalities in the trust, and that's purely predicated on the NHS England Core 20+5 approach, which really only came out towards the end of November. So it really is hot off the press. And in some ways, it works very well for us at Trust, because what I've suggested it allows us to do is map our current clinical work against the Core 20+5. So we can actually demonstrate to ourselves we are already doing and thinking about some work in health inequalities, and it's not necessarily a new thing, but actually in some ways it enables us to be able to sort of communicate where that work is and what's going on. I think that's really important from 2 points of view. Firstly, and I think, Lynn, you might be able to come into this in terms of the Transforming Community Service programme that we're undertaking, and how something called the JSNA is central to that, and that's the Joint Strategic Needs Analysis, and that's where our public health colleagues put together a lot of health-related data and public data with regard to social deprivation and give us a picture of where the greatest areas of needs are. So that is already part of the work at a PCN level and at a service transformation level. So that, that's nothing new for us, but perhaps there's a renewed emphasis on it. And also, just to sort of flag back up the conversation we've had about patient and care experience this morning from the community report, and we talked a little bit about the risk of inequalities, particularly about digital exclusion and what that means. So those are the 2 key points I just want to bring in. But in terms of what will this mean at an organisational level, every year we have a sort of a quality improvement planning round across all of the divisions. And what we're just going to do this year is ask the divisions to think about their quality improvement work that's going on and frame it in terms of the Core 20+5. So we're able to articulate what good work we're doing and potentially where the gaps are with regard to the Core 20+5. So that's just a brief update on where we are with health inequalities and how we intend to promote it. But I'd be interested, bearing in mind, Taneef, that you were at a webinar this morning, whether or not that same focus on Core 20+5, which appears to be the only game in town from NHS England, had that same level of publicity this morning on your webinar.
Thanks very much, John. Hanif, did you want to come in on that point from John about what was covered this morning? I think it's quite helpful that you were at that seminar and we've got this on the agenda. Hanif.
Thank you. Well, first, just in response to John's point, there were 3 speakers at the session this morning, and each one referred to the Core 20+5 in their respective slides, just to highlight the importance of it. And also, interestingly, the chair of the workshop that I attended was Sue Symington, who I hadn't met before, but I think Caroline, you and Michelle and others may know she's the designated chair for the Humber and Vale region and ICS. There were a few takeaways that we probably haven't got time now. I think one of the suggestions that were highlighted is that interestingly, for those of us as organisations that have things like strategy planning sessions and group development board development days, this should absolutely be a thematic area that should be a priority. So I just wanted to put that forward. I know we've got 4 planned for this year, and within that schedule, I think it would be very appropriate, just bearing in mind what John has alluded to, that this is a thematic session, if not for one of the full days, certainly for part of the day. What they asked us to look at, I suppose, the one key point is what they call the golden thread. And I know some of the colleagues will have come across that term before, but that really was health inequalities integrated right across the different facets of the organisation. And I know the golden thread isn't measurable. They did allude to the fact that we're actually awash with policy as far as health inequalities is concerned. And this is the latest one of about 5 that they alluded to. and I'm sure Dean is familiar with that as well. So it's not that we're missing policy. It's more how we're each of us implementing it. Newcastle, North East, and Newcastle seem to be the stars. I know we couldn't attend en masse because it coincided with our board meeting, but 7 of them were present, and they were touted as good practice. I'm not sure if they just said best practice. So hopefully at some point I'd be interested in looking to visit them. But yeah, there's some of the key takeaways, Caroline, just from this morning's session. As it was a very informative session.
Thanks very much, Hanif. And I hear your point. I'm sure everybody does. Is that about policy? It's how we're implementing. And I think, John, your paper today is really helpful to steering us into how to develop into what does this mean about how this is actually implemented and understanding across the organisation, and highlighting the work that's already being done in that area. I've got Dean, and then I have got Lynn.
Yeah, thanks, and thanks, John, and thank you for the paper. I guess in terms of bringing it here, it's a sort of iterative thing, isn't it? And it's good to get that sort of definition and coming forward. I just wondered something in terms of that current policy landscape, whether it's worth just including the new health bill, as it were, in terms of the establishment of ICSs and the statutory duties and responsibilities around health inequalities that are contained in that, and ourselves then as a member of that system, needs to make our contribution to that. And then there was just something as well around employment. Again, we've touched on this before, but we are one of the largest employers in the area. We know that good employment is important to good health, and so the policies and the practices we have about where we recruit, how we recruit, stability of the workforce, good work for people is an important, I think, contribution into our system. And so some of the stuff that Steve's done, for example, about trying to make all new band 2 and 3, apprentice by default, becomes important, I think, in the context of health inequalities as well. And it's just some of that different way that we can think about things. So I really sort of welcome this, and the way that through things like anchor institutions that we can make a contribution on the employment front, not just on the care delivery front.
Thanks, Dean. Very good point. John.
So Dean, really 2 good points. Now, interestingly, you mentioned the ICS. I have covered off the ICS in the paper, and I've suggested perhaps that their approach needs refreshing, because they came out with an approach to health inequalities, which in fairness to them was positive, but it predated all the core 20+5 stuff. So I would go back to, I think everyone needs to do some mapping stuff so we can work out where the gaps are. Your point about the anchor institutions is likewise, again, spot on. I didn't put anchor institutions into this particular paper, but we did talk about health inequalities at our senior leadership forum last week, Dean, where we talked about the role of health inequalities and what us as an anchor institution and what that means in terms of how we do some of our business. So I think you're absolutely right to think we can do something in terms of being an anchor institution. I'm just always a little bit cautious about how we can map and necessarily celebrate that in terms of where we are embedded, but it absolutely has a role to play in thinking about some of this stuff. And hopefully, as we go down the apprenticeship route, which Steve has been helping us develop as an organisation, those are the first steps when you think about social inequalities, because actually what the papers are clear on is that most health inequalities are actually related to social inequalities and deprivation. So unless you can support people through education and development and careers into a proper job with proper housing, actually you're not going to see any benefit in terms of your health inequalities. And I've always been really clear on that, saying that health inequalities, yeah, we can do something about that 15%, but we need the rest of society to think about the 85%, which is related to employment, education and housing. So I hope that helps, Dean.
Thanks, John. Lynn.
Yeah, thank you, Caroline. So I just wanted to build a little bit on John's point, because the golden thread piece as well that Hanif has just mentioned, I do think, we do see that happening in action in relation to our, particularly our significant transformation service redesign programs. So we do use that JSNA data. Obviously, each of our local authorities at place level produce those reports. There are often deep dives into particular areas of inequalities through those reports, mental health and learning disabilities quite often. So, for example, we have utilised that data and will continue to keep on refreshing it in relation to our mental health inpatient redesign programme, where we've modelled some of our bed future capacity in relation to what we understand demographic changes are going to be around some of that. So I'm not, I think there's more that we can do, and I think John's report is really helpful in that. I think we've seen a thread through board today as well, particularly around children. We've got the CQC out of sight publication on the publications report, the SEND inspection that I'm just about to talk to as well, and how that connects really with and triangulates with some of our own data around that, and particularly waiting times. And, you do hear in clinical areas that understanding of the impact of that in relation to health inequalities. I think John's paper really helps set that, in a broader context that we continue to work on as well, to get that sort of golden thread piece right through the organisation, which I think is really important, and that Hanif has raised today.
Thanks, Lynn. Michelle.
Yeah, thanks. I mean, this is just so important in relationship to all the development of the ICS. And Dean was said the point that I was going to make, that actually the core for me of why we're doing the changes in relationship to the ICS has to be to tackle health inequalities, but we can't all do it as a sector. We have to do it with others. So one of the things that I've been working with the health and wellbeing boards to get education and housing included. But what I was going to say is, once we've done our work here, I know it will be ongoing, but I think we do need to feed those into the places. We mentioned earlier that the places are developing. There's that golden thread we've talked about. It needs to make sure it will go into our strategy. We've already said that we will make a bigger emphasis on our strategic direction as we go forward. But I just think we need to make sure that we're sharing that data regularly and information regularly with place as they develop, because it will sit with place. That's going to come out as being really key over the Archer and the ICP. But I do think it's important that we triangulate that information. So great start, John, and it's good to read, but I do think we do need to keep focused on this, and we need to have a conversation about, do we do that at committee level? If so, where? Or if not, do we do it at board? Because I think it's such an important agenda. We should continue to have that dialogue from now on, because it's the one thing we've not done particularly well as a system. I don't just mean as an organisation, but I mean as a system.
Thanks very much, Michelle. I don't see any other hands up. John, do you want to add any final word to
just to pick up
the end of the discussion?
Just a final point, Michelle. Today. Yeah, sorry. Michelle, just to pick up, we can do that once we do that mapping exercise. That will go through quality committee as part of a review of the quality plans for each of the divisions. So we can bring all of that together and perhaps either bring it back to a board workshop or something like that. So people just are sighted on what's going on. And then in turn, we can use that data to feed back into the system. Because I think people will be pleasantly surprised at the amount of work that's going on, but we're just not necessarily sighted on it and joining all of those particular dots.
Thanks very much, John. That's really helpful. So if that work can be discussed further about, what route to take this to identify what we are doing or what more we need to do and how that works with others in the system. I think it's quite important that, I think the Quality Committee is an obvious place, but I think it's also quite important that we have a chance as a board to look at what's happening as well. And I note Hanif's point about a trust board timeout session maybe being utilised for that as well. So thank you very, very much. Thanks, John. Moving on then to the item 20, East Riding SEND inspection. Lynn.
Yes, thank you, Caroline. So obviously this is the special educational needs and/or disabilities inspection that was carried out in relation to the services in East Riding. Obviously it does encompass our services as well that are in that area. So CAMS and our 0 to 19 services and some of our paediatric therapy services. It's a joint inspection, some of you will be very familiar with them, between Ofsted and the CQC. There were 4 key findings in relation to the inspection, and they are primarily related to education, the availability of appropriate school and education placements, and indeed the general support in education for children with those needs. I've pulled out of the report this particular elements of it that did relate to our services. It was great to see that it was acknowledged that the ways of working between our 0 to 19 services and maternity services were reflected as being very good. But unsurprisingly, it also reflects on the impact of some of our waiting times, particularly that neurodiversity pathway. It acknowledges that the development work that they could see was taking place in relation to that, obviously, but at the time of the inspection, I guess they're just cautioning that they want to see the further impact of that work and that new pathway that I've reported here previously. So obviously there is an action plan in place. We continue to work very closely with both our local authority and CCG partners. There's also recommendations you can see around commissioning gaps too, particularly around therapy. So we're working with the commissioners around that area at the moment, but I'm happy to take any questions.
Thank you, Lynn. Any questions to Lynn? No? Thank you for your report there, Lynn. That's received and noted. We move on to 21, vaccines as a condition of deployment. Steve, I think you're heading this up.
Yeah, thanks, Caroline. I know it's come up a little bit earlier in the meeting. So the paper just sets out the position that the regulations ask us to do, and the decisions and tasks that we have to do over the coming months to implement them. So as a kind of position, and these things change almost on a daily basis. So the figures when this paper was written a week ago are different as of today in a positive way. So just to update you on that. So we now know as of Monday, we've got 58 contracted staff that haven't had the first vaccine and need to have it. It will be a condition of their deployment from the 1st of April. And we also got 21 staff that currently work on our bank who are in a similar position. So they need to have that first vaccine. They haven't had it yet, and they will need to be fully vaccinated to work on the 1st of April. In addition to that, we've also got 42 staff who have had their first vaccine but haven't had their second. So they've got a little bit more time to do that, but we still need them to do that to be able to deploy them into their role from the 1st of April. And likewise, 13 bank staff that have had the first but haven't quite had the second. So overall, our figure, that's a really healthy position when we compare ourselves across the patch area. So we get that data on a weekly basis. We can compare ourselves with those other trusts that I mentioned when we were looking at vacancies and sickness. So there's only one other trust in the whole of the patch area that has a smaller number than we do. So I think we're really well positioned. It would be absolutely remiss of me not to mention the work that John did on the vaccine centre and how that helped to get us in this position. So, the work that John and his team put on, the access that we gave to all of our staff, the promotion, I think we've really benefited from that because our take up was so high, and the way we did it was in such an inclusive and thoughtful way. So we're reaping the benefits of that success. That isn't to say that it won't be difficult. Hanif made the point that's still 50 staff potentially that we're in a difficult conversation with come the 4th of February, which is the date that they've got to get that first vaccine. And we'll do that compassionately, and we'll do that sensitively, and we'll do it in a way that we will try and provide other opportunities and do everything we can to avoid dismissal, because that's the employer we want to be. But I think we have to, as a board, understand that redeployment opportunities for those staff are going to be limited. They are going to be limited across the trust. So we've had those conversations. Our managers continue to speak to staff. John, via Liat and his team, continue to offer one-to-one conversations for staff that are vaccine hesitancy, and to try and cover that off. But we will get to a position where that number will be whatever it will be on the 4th of February, and we'll manage it within that. So the paper's provided to hopefully give you assurance that we are managing this as a project. We're doing it in the way that's encompasses our values as an organisation. It's a tricky situation. It's a difficult situation for managers, on top of all of the other pressures that you heard from Lynn so eloquently earlier. But we will manage it, and we are managing it to the best of our ability. Happy to take any questions.
Thank you very much, Steve. And yeah, just to add, I think the work that's been done by everybody in the trust and the work of the vaccination centres as well with John has been tremendous, and it's reflected in the figures you've provided today. Thank you very much. Dean.
Yeah, it was just to give a similar sort of a comment, Carol. I know we picked this up at the Workforce Committee as well, and I know that this is an area that makes people anxious, isn't it? Because it potentially leads to staff leaving the employment. But this is a national policy that the organisation is implementing, and certainly ahead of the Workforce Committee, when I was looking down at the figures, I think as a trust we've got one of the lowest, if not the lowest, rates of unvaccinated staff, both in absolute terms and by percentage. So on both of those sort of areas. And I think some of that, Steve, is down to the fact that we've got good ESR data, given that big clear up that your team did earlier this year in terms of getting that, so whereas other organisations are still going through and validating their data, I think you've been ahead of the game on that there. So recognising it's sensitive, and I think it has been tricky, hasn't it, for organisations to do it, in particular where there's been speculation in the press about whether people will follow through. And I know that is not helpful when we're trying to sort of implement the policy in this way. But really appreciate the update, Steve. Thank you.
Thanks, Dean. Anybody else on this? No, thank you. Thanks very much for that. Item 22, for any items for escalation? No, I don't think so. We move to any other business, and I know Peter wants to raise something, and some of us are aware, but I think to put something on the record. Peter.
Yeah, thanks, Caroline. Yeah, I heard last week the sad news that Vanessa Walker, who former governor and non-executive director to the trust, passed away. She was aged 66. Vanessa was a governor from 2010 and then became a non-executive director before retiring in 2015. And then she became a non-executive director at Huth and also an East Riding councillor. So she always, and you're quite well, she always championed the patient voice in everything that she did, specialising in the health and well-being of the local community that she served. So I'm sure that the board will want to sort of echo my condolences to her family and friends at this sad time.
Thanks very much, Peter. Vanessa was obviously chair of the East Riding Health and Wellbeing Board, and I've obviously just sort of met her in the few months I've been with the trust, and some of you will know her better, but I think she was an incredible public servant in the work that she did, and regardless of everything in terms of her dealing with her health and cancer, every meeting I attended, her commitment, but also her humour shone through these Microsoft Teams that we're all on. And I know our thoughts are with her and her colleagues and friends and family. Thank you for raising that, Peter. So, Michelle.
Yeah, just obviously thanks for raising it. An absolutely remarkable woman. I have, on behalf of the organisation, sent the family some flowers. And obviously I've sent personal cards, but I've sent one on behalf of the organisation as well. The funeral is on the 11th of February, and we will make sure there's some representation. I'd like to go myself if I could, because obviously Vanessa was a remarkable woman, but we'll make sure there's some representation as much as we can within the regulations, etc. But thanks for raising it, Peter.
Thanks very much, Michelle. That's the end of the business for the Trust Board Part 1, the public meeting. So we will be ending streaming shortly. I suggest, given the time, we've run a little bit over than what I expected to be, but I think actually if we have, I would suggest half an hour for people to have a break, not just do your emails, and we'll meet back at, let's say 1:30. Thank you very much, everybody.